Welcome to my study proposal on a prospective cohort study on endotracheal intubation in cardiac arrest. So CPR can be broken down into two basic steps. The first is chest compressions, which circulates blood around the body, and the second is ventilations, which is delivering oxygen to the lungs. The point I'm going to look at for this investigation is the second one, the ventilations. Current practices have you uh, insert an advanced airway to maximize the delivery of the oxygen from whatever delivery device you're using to the lungs. The current preferred device is called an endotracheal tube, which, when you intubate a patient, has a tube from the mouth leading directly into the trachea, so no oxygen is lost into the esophagus or stomach while you're ventilating a patient. So the research question that I'm doing is, does endotracheal intubation in a pre-hospital environment during cardiac arrest without any respiratory or airway complications have a different neurological intact survival rate for patients when compared to in-hospital intubations during cardiac arrest? So over the next couple of slides, I'll just give a basic introduction about the current state of CPR, how it's changed over the last couple of years, how current research is looking at advanced airways, especially in the pre-hospital environment. After that, I'll go over my cohort study and break it down and kind of explain to you how I think I can find a niche where previous studies haven't effectively studied the effectiveness of intubation in out of hospital cardiac arrest when we're specifically looking at how it affects patient outcomes. So there's a fairly obvious reason why we want to have the best resuscitation practices available to us. Eventually, everyone has a cardiac arrest, and we want to be able to maximize the amount of resuscitations we get. Um, However, the American Heart Association says there's about 40,000 cardiac arrests in Canada every year, and the majority of them take place out of a hospital. But when we look at the differences between the survival rates for people who have cardiac arrest in hospitals and when they have them outside of hospitals, there's a big difference. Now, obviously, we'll never have it equal to the chances of survival of out of hospital and in hospital, but providing research to minimize that gap would be a great step in the right direction to maximizing how many people we can revive. So, the next thing is proper oxygenation in CPR is important. The more oxygen you have in your lungs, the more oxygen you have in your blood, the more oxygen that you can circulate around the body when you're doing CPR. So in 2015, at the latest updates, if you look at point 4 on this chart, the American Heart Association just confirmed that by saying maximum oxygen use during CPR is still the optimal um, trend that we can do to get more resuscitations. When looking at all the advanced airways that are available, currently the endotracheal tube is the preferred method for delivering oxygen during a cardiac arrest. However, when studies are looking at the patient outcomes for out of hospital cardiac arrest, they began to notice that patients that had endotracheal tube inserted during an out of hospital cardiac arrest had a higher mortality rate than those who had no advanced airway inserted at all. When we begin to look at reasons for this, there are many more adverse events that can occur in the out of hospital environment when doing advanced airways. Some of them could include in small spaces or low lighting environment where you can't properly see into the airway. which make it much more difficult and makes it much higher chance of failing. Other things are a lack of diagnostic equipment. Sometimes a hospital will just get an x-ray to confirm where the airway or the endotracheal tube is, whereas in the pre-hospital environment, we don't have those methods available to us, resulting in a higher chance of having a misplaced endotracheal tube. So this has led some studies to suggest that perhaps an endotracheal intubation is not appropriate in out-of-hospital environments for cardiac arrest. However, I believe that there is a gap currently present in these studies, since they have not looked at uncomplicated cardiac arrest. They just look at every single cardiac arrest that's been done and looks at the total mortality rate. There's been little research done to see if you eliminate adverse events or signs of difficult intubations, uh, if the people who have no signs of being difficult to intubate are more likely to benefit from an endotracheal intubation. So the purpose of this study is to attempt to determine if there's a set of conditions in which intubating in an out-of-hospital cardiac arrest will increase the patient's chances of resuscitation. So what I am attempting to do is getting rid of all the adverse events or high risk factors in intubation and just analyzing intubations that are successful without any complications, and seeing if those proper intubations lead to increased patient outcome when compared to similar intubations in hospitals. So, to give an overview of my prospective cohort study, I did a little map of how I imagine the study would run. So, when I would have a cardiac arrest with an endotracheal intubation in the area that I am performing the study, uh, I would determine if it was out of hospital or an in hospital environment in which the cardiac arrest occurred. If it was out of hospital and any exclusion criteria were met, I would eliminate that population from the study, and this will allow me to assess the out of hospital cardiac arrest survival rate of the most optimal people who would have the greatest chance of having a favorable neurological outcome and recovery from the cardiac arrest. I didn't add an exclusion criteria to the in-hospital cardiac arrest population, primarily because this study is looking at raising the out-of-hospital cardiac arrest to meet the in-hospital cardiac arrest population, as well as in hospital you have much more or many more resources available, which are there to specifically address these high risk or adverse events. So they really don't need an exclusion criteria as well. And so when I was looking at how to select a population, there is no nationwide database or continent-wide database in the Canada or US that currently tracks cardiac arrest outcomes. Um, there are some small localized databases that have started to record information on cardiac arrest and how they are treated. Example is there's one run out of St. Michael's Hospital that does the GTA and just records data of cardiac arrest around that area. But there is no nationwide database where you can get the entire population of Canada or of a province and the data associated with that. So, with that in mind, I decided that from a logistical standpoint, it would be easier to deal with a local health network where I would only have to deal with one set of hospitals and one set of uh, ambulance or emergency medical services system. So I wouldn't be trying to compare apples to oranges if their paperwork is greatly different in between multiple services. So for my selection criteria, um, obviously there has to be a cardiac arrest with endotracheal intubation performed. I also put in as a criteria a successful intubation achieved on the first attempt, which means it was an easy intubation with no complications met. For the exclusion criteria, there are certain populations that have been documented to be harder to intubate. Any traumatic arrest is sometimes harder, especially if there's any airway trauma or trauma to the head. Any pediatric arrest, it's just their airways aren't fully developed yet, and it's not something paramedics or healthcare providers have a lot of practice dealing with unless they have specialized in it. And any obese patients, just when obesity comes in as a factor, it's hard to manipulate all the tissue as you're trying to intubate a patient. And the second criteria that I have is any complication arising from intubation. So if missed intubation was unrecognized, this is probably one of the more serious ones where if they accidentally intubated the esophagus and didn't realize it, usually it'll be documented when they arrive at the hospital that the the intubation tube was in the esophagus and not in the trachea. Aspiration during intubation, that is when vomit goes into the trachea and it actually goes into the lungs. That also usually is a bad sign and makes it harder to treat the patients. Bronchial intubation is when the tube is pushed too far in and it actually goes into one of the lungs and only half the lungs are oxygenated, or any prolonged hypoxia, which is an intubation that takes more than 30 seconds. If you're intubating, the patient isn't breathing, so that's 30 seconds where there's no oxygenation occurring. So for my exposure variables, there's two main ones. First is a uncomplicated out-of-hospital cardiac arrest where an intubation occurs, and the second one is an in-hospital cardiac arrest which has an intubation as well. And just uncomplicated out-of-hospital cardiac arrest just means it's in there's no exclusion or high risk criteria is met, and that the intubation occurred on the first attempt. And with that in mind, this study would need to occur in a system that records the demographics of either high risk or also any adverse events that occur during intubation, so I can exclude them from the study. So for my outcome variable, I decided to have it being a return of spontaneous circulation, which is basically the heart starts beating on its own without any assistance, and also the patient has a favorable neurological outcome, which basically means their brain got enough oxygen during the arrest so that they didn't get any brain damage. And to measure the neurological outcome, there is something called the Cerebral Performance Category Scale, which is often used in this situation, whereas a 1 or a 2, as you can read, is a good outcome, and anything below that is a bad outcome. So it allows for moderate disability, but they still need to be conscious and alert to who they are, what day it is, and other basic things like that. And just for the outcome, it will be measured at the 1 month mark after the cardiac arrest occurs. And that's just to ensure that whatever recovery they have, it is a permanent one and not a temporary return of circulation and then later they rearrest. But we want to make sure that whatever they have is a permanent one. Usually by 1 month, any effects that happen, any negative effects, like if they do die after 1 month, it's for some other reasons. And if the patient is discharged from the hospital before the 30 days, we're just assuming that they have a favorable outcome because you don't send a person home if they aren't healthy. If they can walk out the front door, then we're assuming that they have that favorable outcome. So when deciding what data analysis to do, I borrow a slide from our measurement and data analysis lecture, and we're looking at our variables. We have two dichotomous variables, the first one being either an in-hospital or out-of-hospital cardiac arrest with intubation, so there's only two choices there, and our outcome variable is either they have a return of spontaneous circulation with favorable neurological outcomes, or they do not have. So again, either one of two. So obviously it's either chi-squared test or logistic regression. When I was researching the other topics in my literacy review, I noticed most of the studies had used logistic regression, so I figured it was best to do odds ratio with logistic regression, so it'll make it easier compared to other studies. So for my selection criteria, obviously there has to be a cardiac arrest with endotracheal intubation performed. I also put in as a criteria a successful intubation achieved on the first attempt, which means it was an easy intubation with no complications met. For the exclusion criteria, there are certain populations that have been documented to be harder to intubate. Any traumatic arrest is sometimes harder, especially if there's any airway trauma or trauma to the head. Any pediatric arrest, it's just their airways aren't fully developed yet, and it's not something paramedics or healthcare providers have a lot of practice dealing with unless they have specialized in it. And any obese patients, just when obese. So for this prospective study, the cohort study, it is largely observational. There's no change in the treatment of the patient, no change on when they will or will not intubate. So largely there is no ethical issues. For the prospective nature of the study, it's just more observationally seeing if they're neurologically intact compared to a point before their arrest, or if their heart started beating on its own. So again, no changes in treatment when I'm observing them. And the biggest issue that I would say is there's just a lot of confidential information being accessed. That could always be abused, but as long as you respect confidentiality, I believe it will be approved by an ethical board. So there are a couple of limitations with this research. If there's any incomplete documentation, that would be a big problem. It's hard to send research or hard to send paperwork back to a medical professional because they might forget what happened, or they might be more willing to document that it was more favorable than it actually was. So that could create a bias if there's incomplete paperwork, and it probably would need to be excluded from the study. There's been some research into experience playing a role with the healthcare provider, especially paramedics, for intubations. We don't know if this is their first intubation or if this is their 200th. So another issue with this study is documentation of airway management is always tricky because it's usually one person at the head, and that person documents what they saw and what they did. If they weren't keeping an eye on the time, for example, and they took more than 30 seconds to attempt an airway, but they did not think that they took that long, then it could be falsely reported as not being an adverse event. So it largely relies on honesty and situational awareness. If someone makes a mistake, it's largely dependent that they come forward and say, I made a mistake. So for my outcome variable, I decided to have it being a return of spontaneous circulation, which is based